Today we're going to be talking about the Lindsay Clancy trial. So we're going to be opening by beginning with the children. Before I say anything about psychiatric diagnosis, medications, telehealth appointments, or the mental health system, I want to begin with the three children at the center of this case: Cora, Dawson, and Callan. They were not simply names in a court case. They were children with personalities, people who loved them, and futures that should have had the opportunity to unfold. Their deaths are an immeasurable tragedy. Nothing I discuss in this video is intended to minimize their loss, excuse what happened, or shift attention away from the three lives that were lost. Examining the psychiatric care Lindsay Clancy received does not mean choosing her over the children. We can grieve Cora, Dawson, and Callan while asking difficult questions about psychiatric diagnosis, medication management, continuity of care, communication between providers, and whether signs of deterioration were fully understood. Those questions matter because examining psychiatric care is not about rewriting what happened. It's about asking whether there are lessons that could help protect another patient, another family, and other children in the future. So before we go any further, I want to say their names once more: Cora, Dawson, and Callan. Their lives matter. Their loss matters. And they must remain at the center of this controversy. So before we go any further, I want to be very clear about my role in this discussion. The trial is ongoing. I'm not the judge. I am not the jury. I was not one of Lindsay Clancy's treating clinicians. I never evaluated her, and I did not have access to her complete medical record. So I am not diagnosing Lindsay Clancy from a courtroom or from news reports. And I'm not going to tell you whether a particular clinician was negligent based on selected pieces of testimony. That's not what this video is about. What I can do is discuss the clinical questions being raised in this trial through the lens of a psychiatric mental health nurse practitioner, because that is the work that I actually do. And when I evaluate and treat a psychiatric patient, I'm not simply looking at a diagnosis and writing a prescription. I order laboratory testing when it's clinically indicated. I look for medical conditions that could be contributing to a psychiatric symptom. I review medications, not only psychiatric medications, but the complete medication picture. I request and review medical and psychiatric records when they're important to understanding what has happened before the patient came to me. I look at previous hospitalizations, previous diagnosis, previous medication trials, what worked, what didn't, what caused side effects. And when other clinicians are involved, I coordinate care, because psychiatry doesn't exist in a vacuum. If my patient is deteriorating, I need to understand what the other people caring for the patient are seeing too. And sometimes that means talking with another provider. Sometimes it means reviewing hospital records. Sometimes it means obtaining collateral information from family when appropriate. And sometimes it means ordering labs. Sometimes it means reconsidering the diagnosis entirely. And sometimes it means something about this picture doesn't make sense. I need more information. That's the perspective I'm bringing to the case. I'm not here to determine guilt. I'm not here to determine legal responsibility. And I'm not here to Monday morning quarterback clinicians who complete records I have never seen. I'm here to ask what psychiatry can learn from the questions this testimony is raising. Because if we can learn something that helps another provider recognize deterioration sooner, ask one more question, coordinate care more efficiently, or look beyond the diagnosis already written in the chart, then I believe that's a conversation worth having, and that's where I want to begin. So this brings me to the question I keep coming back to. What should psychiatric providers learn when someone continues deteriorating despite being surrounded by care? Because receiving treatment and getting better are not necessarily the same thing. A patient can have appointments, they can have prescriptions, they can have a psychiatrist, a therapist, a primary care provider, maybe even recent hospitalizations, and still be getting worse. And when that happens, I think we have a responsibility to become more curious, not simply more aggressive with treatment. If a patient keeps deteriorating, I don't want my only question to be, what medication should I try? I want to ask, what am I missing? Does the diagnosis still make sense? Has something changed? Is this actually depression and anxiety? Or is there something developing that wasn't apparent at the beginning? Could this be bipolar disorder? Could this be psychosis? Could there be an obsessive or intrusive thought that the patient is afraid to disclose? Could the patient be having an adverse medication reaction? Could medications be interacting with one another? Could sleep deprivation be changing the clinical picture? Could there be a clinical condition contributing to what I am seeing? What does the family see I'm not seeing during a short appointment? And maybe one of the most important questions, what has changed from the patient's baseline? Because psychiatry cannot be done with just a series of snapshots. A mental health examination tells me what someone looks like right now. It doesn't necessarily tell me what happened 3 nights ago. It doesn't tell me that this person who normally sleeps 8 hours has barely slept for 5 nights. It doesn't tell me that their spouse says, this is not the person I know. And it doesn't tell me they stopped functioning at home. That's why the trajectory matters. If I saw you 3 weeks ago and you were anxious, and then 2 weeks ago you weren't sleeping, last week you told me you felt emotionally numb, and today you're sitting with me telling me that you have thoughts frightening you, I can evaluate today's appointment as though those other appointments never happened. I have to put those pieces together. And that becomes even more important when multiple clinicians are involved, because one provider may know about the insomnia, another may know about the intrusive thoughts, and another may have changed medications, and they may know what happened during a hospitalization. And the family may be holding another piece of the puzzle entirely. If nobody puts the pieces together, everyone can be providing care while nobody has the complete picture. That's something I think healthcare has to take seriously. And medication deserves particular attention when someone is deteriorating. Psychiatric medications can be incredibly helpful. I prescribe them. I believe in them. But prescribing also requires us to watch what happens after we prescribe. Does the patient improve? Did they get worse? Did something new appear? Did their sleep change? Did agitation increase? Did they become unusually restless? Did their changing think? Did symptoms become after starting a medication or changing a dose? Those questions don't automatically mean the medication caused the problem. Correlation is not causation, but it is a relationship that deserves investigation. And sometimes that answer isn't another prescription. Sometimes it's another question, another set of labs, another review of the medication list, another conversation with the family, with the patient's permission, when appropriate, or within applicable safety and privacy expectations. Another look through the hospital records, another reconsideration of the diagnosis, or simply recognizing something about this clinical picture does not make sense. And I think clinicians have to be comfortable saying that. We don't always know. Psychiatry contains uncertainty. Patients don't always walk into our office fitting perfectly into DSM criteria. Symptoms evolve. People can minimize their symptoms. They may not understand what's happening to them, and sometimes they don't have the language to describe what they're experiencing. So if I ask, are you having thoughts of wanting to hurt yourself? And the patient says no, that tells me something important, but it doesn't tell me everything. If I ask, do you want to hurt anyone? And they say no again, that matters. But psychiatric assessments cannot end with two boxes marked no. I may need to ask, are you having thoughts that scare you? Are you seeing images in your mind that you don't want to see? Do you ever feel like you're losing control? Have you ever had thoughts that feel unlike you? Do you hear or see things other people don't? Do you believe something is happening that your family says isn't happening? How much are you sleeping? What does your partner think has changed? Those questions can uncover a very different clinical picture. And this is where time becomes important. We work in a healthcare system that rewards productivity. See the next patient, finish the documentation, answer the messages, fill the medications, move to the next appointment. I understand those pressures. I've worked under them. But a human mind is not a checklist. Sometimes the thing that changes your entire assessment comes in minute 18. Sometimes it's the question you almost don't ask. Sometimes the patient puts their hand on the doorknob and says, oh, there's one more thing. And suddenly you realize disappointment is not what you thought it was. That's why deterioration should change the way we think. If treatment is working, wonderful. But if someone continues getting worse despite treatment, that's clinical information. It should make us stop, reassess, look at the timeline, review the diagnosis, review the modifications, look for medical contributions, other collateral information when appropriate, review previous records, and ask better questions. Not because every tragedy can be predicted, it can't. Not because clinicians can eliminate every risk, we can't. And not because every poor outcome means somebody did something wrong, it doesn't. But because when a patient is telling us through their symptoms, their functioning, their behavior, or their response to treatment that something isn't working, we have to be willing to listen to that information. And sometimes the most clinical, responsible thing we can say is, I need to look deeper. This, to me, is one of the biggest lessons psychiatry should be willing to take from cases like this. Not that we need to practice psychiatry faster. Not that we need another checklist. But that when clinical pictures doesn't make sense, we keep asking until we understand as much of that picture as we possibly can. Now I want to look at something that I think is incredibly important in this case. Not one appointment, not one medication, not one diagnosis, the trajectory. Because when we're evaluating someone psychiatrically, we can't just ask, how does the patient look sitting in front of me today? We have to ask, where was this patient 3 months ago? Where are they now? And when I look at the testimony that has been presented in the Lindsay Clancy trial, that's the question I keep coming back to. According to testimony, this woman was experiencing a significant psychiatric symptom over a period of months. There was anxiety, depression, severe difficulty sleeping, emotional numbness and detachment, intrusive thoughts, suicidal thoughts that were reported at points in her treatment. And according to Patrick Clancy's testimony, from his perspective, she kept getting worse. Now, I need to be very careful here. I'm not saying that proves anyone was negligent. It doesn't. I'm not saying that a particular provider should have known what ultimately may have happened. And I'm certainly not saying that every tragedy can be predicted by a psychiatric provider. It cannot. What I'm saying is that the testimony raises important questions for us who practice psychiatry. because this wasn't someone who wasn't seeking help. She was seeking help. She saw multiple mental health professionals. She received numerous psychiatric medications and medication changes. She had an emergency department evaluation. She had a voluntary psychiatric hospitalization at McLean Hospital. And yet the testimony described a clinical picture that continued to be complicated and at various points worsening. And I think that's where we have to stop looking at the individual appointments and start looking at the whole picture. So, the medication picture. One of the major issues being argued in the trial is medication. The defense has characterized Lindsay as overmedicated. The prosecution disputes aspects of that narrative, including questions about what medication that she was actually taking, and I'm not going to decide that question from a YouTube video. But the number of medications and medication changes described in testimony absolutely raises a clinical question. Who had the complete medical list? Because when multiple people are prescribing, one provider may be discontinuing medication, another may be starting something, one may be changing a dose, the patient may report a side effect to one clinician that another clinician never hears about, and unless someone steps back and reconciles the entire medication history, we cannot end up treating pieces of a patient instead of treating the patient. Testimony from psychiatric nurse practitioner Rebecca Gelada highlighted exactly this kind of concern. Under cross-examination, she acknowledged that she did not have the complete information from Lindsay's other providers and had not consulted with another psychiatrist or hospitals involved in her care. Again, that is testimony. It's not my finding of negligence. But as a psychiatric provider, it makes me ask, who's putting this puzzle together? And then there is sleep. This is another part of the trajectory that really gets my attention, sleep. Testimony describes significant insomnia, including periods of extremely limited sleep, and an episode in which Patrick and Lindsay had gone approximately 48 hours without sleeping. Sleep is not a little box at the bottom of my psychiatric evaluation. I want to know, how many hours are you sleeping? Has that changed? Can you fall asleep? Can you stay asleep? Do you feel tired but unable to sleep? Do you feel like you don't need sleep? What happened to your thoughts when you aren't sleeping? Because severe and persistent sleep disruption can dramatically change a psychiatric presentation. So if someone tells me I'm barely sleeping, and then they come back and they're still barely sleeping, that becomes part of the trajectory. I don't want to keep documenting sleep poor. I want to know why. And this is where appointment length matters. Now we're going to get into something that I know may be uncomfortable. How much we can reasonably evaluate in a very brief psychiatric appointment. I have talked briefly about my concerns with the 15-minute psychiatric medication management model. Can some stable patients appropriately have a short follow-up? Absolutely. Someone I treated for years, they're stable, medication's working, nothing's changed, they're sleeping, they're functioning, they're not having side effects. That's very different. But we're not talking about that patient. We're talking about someone whose clinical picture is changing, someone with worsening insomnia, medication changes, increasing distress, intrusive thoughts, functional changes, possible suicidal thinking. At some point I have to ask, is 15 minutes enough? Not, can I technically complete this appointment in 15 minutes? Can I truly understand what's happening? Can I review the medication history? Can I assess sleep? Can I assess safety? Can I explore intrusive thoughts without frightening the patient into shutting down? Can I look for activation, mania, psychosis, akathisia, medication effects, substance use, or medical contributors? Can I review what happened at the hospital? Can I find out what another medical provider changed? Can I ask the spouse or family what they were seeing that was clinically appropriate? Can I give the patient enough time to tell me the thing they may be terrified to tell me? Because sometimes the most important information doesn't come out in minute 3. Sometimes it comes out after you've built enough trust for the patient to say, there's something else I haven't told you. And then there's telehealth. I want to be careful here. I use telehealth. Telepsychiatry can be appropriate, effective, and enormously valuable. For many patients, it increases access to psychiatric care they otherwise may not receive. So my takeaway from this case is not telehealth is bad, but testimony in this trial has raised questions about providers who treat Lindsay virtually and about the information available to them. The defense specifically challenged one psychiatrist over virtual-only encounters, and that raises a legitimate clinical question. When does a patient's deterioration require us to change the level of format of care? If someone is stable and I've known them for years, telehealth may work beautifully. But if someone is rapidly deteriorating, and if I'm questioning the diagnosis, if medications are changing repeatedly, if sleep is severely disrupted, if I'm worried about psychosis, if I'm worried about mania, if I'm worried about safety, I think we have to be willing to say, I need to see you in person. Or there needs to be a higher level of care. Or I need collateral information. Or I need your hospital records before I can make another major treatment decision. Or even, I don't completely understand what I'm seeing and we need to slow down. This isn't a failure. That's clinical judgment. And then there's a bigger problem, fragmentation. And maybe this is the part of the testimony that concerns me most as a psychiatric provider. Multiple people can be doing their individual jobs, and the overall system can still become fragmented. One person sees anxiety, someone else sees insomnia, someone changes a medication, someone evaluates the suicidality, someone sees a patient in the hospital, someone sees a patient after discharge. But who sees the whole patient over time? That's the question. Because if every appointment begins at 0, we lose the trajectory. And psychiatric diagnosis depends heavily on trajectory. What changed? When did it change? What happened immediately before it changed? What medication was started? What medication was stopped? What did the patient family notice? What did the hospital notice? What did the previous provider notice? What does the entire timeline tell us that one appointment cannot? That's why I don't look at the testimony in this case and immediately say, this provider caused this. I don't know that. And neither does anyone else watching a few clips from a trial. That's what court, experts, evidence, and ultimately a jury are there to evaluate. But I can look at the questions this testimony raises and say, psychiatry has something to learn here. When a patient continues deteriorating despite receiving care, more treatment isn't automatically the answer. Another prescription isn't automatically the answer. Another 15-minute appointment isn't automatically the answer. Sometimes we need to stop, get the records, talk to each other, reconcile the medication, reconsider the diagnosis, look at the sleep, look at the timeline, look at the family, look at the patient again, and ask, what are we missing? Because sometimes the most important thing a psychiatric provider can do isn't add something else. It's recognizing that the story in front of us no longer makes sense and take the time to figure out why. So with that boundary established, there's one question I keep coming back to as I listen to the testimony in this case. How can someone be surrounded by psychiatric care and still become progressively more unwell. Because Lindsay Clancy wasn't someone who never sought treatment. She was receiving psychiatric care. She had providers, medication, she had medication changes, she had evaluations, she had psychiatric hospitalizations. There were multiple points of contact with the mental health system. And yet, according to the testimony presented at the trial, there were continuing concerns about anxiety, depression, significant sleep problems, emotional changes, intrusive thoughts, and changes in her functioning. So, as a psychiatric provider, I don't want to just ask, was she receiving treatment? I want to ask, was the treatment changing as the patient changed? Because those are two very different questions. A patient can attend every appointment, take every medication exactly as prescribed, answer every question they've asked, and still be deteriorating. That's when the trajectory becomes incredibly important. Are their symptoms getting better? Are they getting worse? Are new symptoms appearing? Has sleep dramatically changed? Has functioning changed? Is the family describing someone different from the person we're seeing during the appointment? Has medication been started, stopped, increased, or decreased? Did another provider make a change that I don't know about? Was there an emergency department visit or hospitalization whose records I haven't reviewed? Does the diagnosis that we started with explain what we're seeing now? And then there's another question I think sometimes we don't ask enough in healthcare. Who has the whole story? Because having several providers doesn't necessarily mean those providers have the same information. One clinician may know about the insomnia, another may know about the medication reaction. A therapist may know about a frightening thought the patient was too embarrassed to tell the prescriber. The spouse may be watching dramatic changes at home that no one else sees during an appointment. And the hospital may have missing information sitting in a medical record that the outpatient provider hasn't received yet. Everyone has a piece of the puzzle. But who is putting those pieces together? And that's what I mean when talking about continuity and coordination of psychiatric care. And I think that's one of the most important questions this case raises for our profession. Because when someone continues to deteriorate despite treatment, that deterioration itself becomes clinical information. It should make us curious. It should make us reassess. And sometimes make us say, wait, something's changed here. Before we do anything else, I need to understand why. And that brings us directly to Lindsay Clancy's clinical trajectory, because when we put the symptoms, medications, providers, hospitalizations, and changes over time together, some very important questions begin to emerge. Now I want to look at the clinical trajectory, and I want to be very careful with my language here. I'm discussing issues that have been raised through testimony in an ongoing trial. And I'm not saying these facts establish negligence. I wasn't there. I didn't treat Lindsay Clancy. I don't have her complete medical record. And ultimately, determining legal responsibility belongs in the courtroom. But as a psychiatric provider, I think the testimony raises clinical questions that our profession should be willing to discuss. Because when we look at the course of Lindsay's psychiatric treatment, we're not talking about one isolated symptom or one appointment. We're talking about a patient whose presentation appears to have been changing over time. The symptoms are changing. Testimony has described significant anxiety, depression, severe insomnia, emotional numbness or feeling disconnected, changes in functioning, and other concerning psychiatric symptoms at different points in her treatment. And one of those symptoms by itself may not tell us what's happening. When symptoms begin accumulating or changing, that's when I want to stop looking at them individually. I want to ask, what does this pattern mean? And especially, is this patient getting better, staying the same, or getting worse? Because if somebody is receiving treatment and continuing to deteriorate, That's an important clinical information I must have. And then we have medication history. Another major issue raised during the trial has been the number of psychiatric medications prescribed and the changes that occurred during treatment. And I want to emphasize something here. The number of medications alone does not prove inappropriate prescribing. They are legitimate clinical circumstances where medications are started, discontinued, changed, or used for relatively short periods. That's why context matters. My question isn't simply how many medications did she receive. I want to know, why was each medication started? What symptoms were we targeting? What dose was used? How long did she take it? Why was it increased? Why was it decreased? Why was it stopped? Did she improve? Did she experience side effects? Did something new develop after a medication change? And more importantly, who's tracking all of this over time? Because when treatment becomes complicated, medication reconciliation becomes incredibly important. Multiple providers can create another challenge. Having multiple psychiatric providers isn't automatically a problem. Sometimes it's necessary, but it creates another clinical question. Does everyone have the same information? Because imagine what happens when one provider has part of the story and another provider has another, the hospital has another, the therapist knows something else, and the family is seeing changes at home. Each person may be making a reasonable decision based on the information available to them, but nobody has the entire picture. Treatment can become fragmented, and that's where the record matters. If a patient has recently had a psychiatric hospitalization, I want those records. If another psychiatrist recently changed medications, or any psychiatric provider, I want to know what was changed and why. If there were laboratory results relevant to the treatment, I want to review them. And if another clinician documented symptoms that the patient isn't reporting to me today, I want to know this too. Because psychiatric care should not begin from zero every time a patient walks into the office. And that brings me to appointment length. This is something I feel strongly about because I practice in systems where productivity matters. There's a place for a brief medication management appointment. I've seen stable patients I've known from a long time. They're doing well. The medication hasn't changed. They're functioning. They're sleeping. They're not reporting new symptoms or significant side effects. The patient doesn't need an hour with me every time I see them. But a deteriorating patient, that's different. If somebody's symptoms are changing, they're sleep deprived, their medication has changed repeatedly, they've had a recent hospitalization, the functioning is declining, or I'm questioning whether the original diagnosis still explains what I'm seeing, I don't believe that's enough time to rush through a 15-minute appointment or even a 25-minute appointment, because I need to ask what's changed, when did it change, what are you taking, when did you stop taking it, how are you sleeping, what thoughts are you having that you haven't told anyone about, what happened at the hospital, and what does your family see, and is there something medically that we need to investigate? Sometimes the most important information comes after the patient finally feels safe enough to tell you. You always can't put a timer on that. And then there's telehealth. I also want to be very clear about this. I practice telehealth. I believe telepsychiatry has an important place in medical health care. It has improved access. It works extremely well for many of my patients. So I'm not suggesting that telehealth caused what happened here. That would be an enormous conclusion that the evidence does not allow me to make. But I do think this case raises another question. When does the clinical picture tell us that telehealth may no longer be enough? If I have a patient who is significantly deteriorating, if I'm questioning psychosis, mania, a serious medication reaction, severe functional decline, or safety, there may come a point where I say, I need to see you in person. Maybe I need vital signs. Maybe I need a physical assessment. Maybe I need laboratory testing. Maybe I need someone else to evaluate you. Maybe I need collateral information. Or maybe outpatient treatment itself is no longer the appropriate level of care. That's not an indictment of telehealth. That's adjusting the treatment to the patient's changing condition. And that's what keeps bringing me back to the trajectory. This isn't about going backwards and saying someone should have known exactly what was going to happen. Psychiatric providers can't predict every act of violence, suicide, or tragedy, and a terrible outcome does not by itself prove that somebody provided negligent care. But when we ask, was the patient improving? Was she deteriorating? Was new symptoms emerging? Was medication changing? Did every provider have the information they need? Were records being reviewed? Was care being coordinated? Was the amount and format of contact appropriate for complexity of the presentation? And at what point does continued worsening of symptoms require us to say something we're doing isn't working? We need to stop and reassess this entire picture, because sometimes the warning isn't one dramatic symptom. Sometimes the warning is the trajectory itself, and that's an important distinction. A psychiatric appointment is not a snapshot. Good psychiatric care has to look at the whole movie. This brings me to something I think is incredibly important in psychiatric care. When patients ask questions like, are you having thoughts of hurting yourself? Are you having thoughts of hurting someone else? And sometimes the answer is no. That answer matters. I absolutely want to know whether my patients are experiencing suicidal or homicidal thoughts, and whether there is intent, whether there is a plan, and whether there is access to a means. But here's where I think we have to be careful. A no cannot be the end of a psychiatric evaluation, because human beings and psychiatric symptoms are much more complicated than just a yes or no question. A patient can truthfully tell me, no, I don't want to hurt myself, and still be experiencing symptoms that concern me. A patient can truthfully say, no, I don't want to hurt anyone, and still have frightening, intrusive thoughts or images that they don't understand and they're terrified to disclose. Those are very different things. So I ask different questions. Are you having thoughts that scare you? Are those thoughts or images that keep coming into your head or your mind even though you don't want them there? Are you hearing a voice that other people don't want to hear? Are you seeing things other people don't see? Have you started believing something that people around you tell you isn't happening? Do you feel afraid that you might lose control? And then I listen, not just for yes or no. I listen to how the patient describes the experience, because the clinical meaning can be very different. Intrusive thoughts are not automatically intent. The distinction is incredibly important. Someone with OCD, for example, can experience a horrifying, intrusive thought that is completely inconsistent with what they want. They may be frightened because they don't want the thought. That's very different from someone describing an intention, desire, or plan to act. So if I simply say, do you want to hurt anyone? And stop when the answer is no, I may never learn about the symptoms the patient is actually struggling with. And the patient may not volunteer it. And here's why. Because they may be terrified of what I'm going to think. They may be thinking, if I tell her, she's going to think I'm dangerous, or she's going to hospitalize me, or what kind of person even thinks something like this. That's why how we ask these questions matter. I also want to know about reality testing. If something in the presentation concerns me, I may need to explore much more than suicidal or homicidal thoughts. Is the patient hearing voices, seeing things, experiencing paranoia, having unusual beliefs? Are they convinced something is true despite evidence that it isn't? Are they experiencing significant confusion or disorganization? Do they recognize that something about their thinking has changed? And importantly, is that different from their baseline? Because someone doesn't have to walk into my office announcing, I'm psychotic. They may not understand what's happening to them. They may genuinely believe what they're experiencing is real. And then sleep. I want to know about sleep. Not, are you sleeping okay? And then move on. I want to know how many hours. When did that change? Are you exhausted and unable to sleep? Are you sleeping very little and somehow you don't feel tired? Did this begin on or after a medication change? Have you ever gone in an entire night without sleeping? 2 nights. What happened to your thoughts when you haven't slept? Because severe insomnia can be an important piece of changing psychiatric presentation. And then medication changes matter. That's why I want to know, what medications are you actually taking? Not just what's listed in the electronic medical record. What are you putting into your body every day? When was it started? When was it stopped? When was it increased? When was it decreased? What are you taking as needed? Are you taking anything prescribed by another provider? Supplements, over-the-counter medication, substances, and more importantly, what changed after those changes were made? If somebody tells me ever since we changed that medication I don't feel like myself, I'm going to explore that. It doesn't automatically mean the medication caused it, but it gives me information I need to investigate. This is another area where a simple safety checklist can miss something important. Maybe the patient denies suicidal thoughts, but 3 weeks ago they were going to work. Now they're calling out every day. Now they stopped taking a shower, and now they're not eating normally. They're no longer caring for their children the way they usually do. They stopped answering friends. They aren't paying bills. They're behaving in ways their spouse has never seen before. That change matters. Sometimes deterioration shows up in function before a patient has the words to describe what's happening to them. And sometimes the family sees it first. With appropriate consent and when legally and clinically appropriate, collateral information can be incredibly valuable. I may ask, what are you seeing at home? Because a person sitting calmly in front of me for 20 or 30 minutes may look very different from the person their family has been living with for the past 3 weeks. A spouse may tell me she hasn't slept, hasn't been eating, she barely talks anymore, her spending is in a way it's never been before. Something is different, I can't explain it, but this isn't her or him. I don't automatically accept another person's interpretation as a diagnosis, but I absolutely consider the information. And finally, again, I looked at that trajectory. This may be the most important part. What did you tell me last week? What did you tell the therapist? What happened during the emergency department visit? Why were you hospitalized? What did the discharge summary say? What has happened to your sleep? What medications has changed? What is your family noticing? Are you functioning better or worse? What directions are we moving? Because risk isn't always a single dramatic moment. Sometimes it's a pattern developing across several weeks. And if I only looked at the day's appointment, I may miss the pattern. That's why a checklist isn't enough. Checklists have a purpose. Structured suicide assessments have a purpose. Asking directly about suicidal and homicidal thoughts absolutely has a purpose, but they support clinical judgment. They don't replace it. A patient isn't suicidal, check a box, no. Homicidal, check a box, no. Hallucinations, no. Follow up in 4 weeks. there's a human sitting behind those boxes. And if something about that presentation doesn't fit, if their family is concerned, if their function is declining, if they're barely sleeping, if medication keeps changing, if they're describing thoughts they don't understand, or if my clinical judgments or instincts are telling me something's different here, I'm going to keep asking, because sometimes the most important questions in psychiatry come after the patient has already said no. And here's why I keep coming back to this. A human mind is not a checklist. And why this is so personal to me. This part of the conversation is very personal for me, because I've worked in an outpatient psychiatric setting where time and productivity matters a lot. At my last outpatient job, I was reprimanded more than once for spending too much time with patients. I was told my appointments were taking too long, and I was also criticized because I ordered what some people considered too many labs. But here's the thing. If I'm treating someone's mental health, I need to know whether something is happening physically that could be contributing to what I'm seeing psychiatrically. If someone comes to me exhausted, depressed, or unable to concentrate, or they're experiencing significant changes in mood, I'm not automatically going to assume this is psychiatric. Depending on the patient, the presentation, I may need laboratory testing. I may need to look at thyroid testing, anemia, vitamin deficiencies, metabolic issues, medication levels when appropriate, kidney or liver functioning, depending on what I'm prescribing, and other medical contributors suggested by their history and symptoms. Because sometimes what looks psychiatric isn't entirely psychiatric. And in my past jobs, I was criticized for requesting records. Oh, there are too many pages coming through our fax. But if you were hospital last month, I want those records. If another psychiatric provider treated you before you came to me, I want to understand why they saw you. What diagnosis did they consider? What medication did they try? What happened? Why was something discontinued? What was the side effects? What did the hospital observe that I didn't see during our appointment today? I'm not requesting records because I enjoy having more paperwork to read. I'm trying to understand the patient sitting in front of me. And then there's the issue of time. If a patient was struggling and needed more than the scheduled appointment, sometimes I stay longer, because there are appointments where 15 minutes might be perfectly adequate, like I said. A patient I've known for years, they're stable, they're sleeping, they're functioning, the medication's working, no significant side effects, no new safety concerns. That is one situation. Okay, I've said that 3 times now. But if someone walks into my office and says, something's wrong, I don't feel like myself, then I discover they haven't been sleeping, their functioning has changed, they have thoughts that have frightened them, they recently had several medication changes, or their family is telling me they're seeing an entirely different person at home. I'm not looking at my clock and saying, well, your 15 minutes is up. This patient needs something different from me that day. And yes, sometimes that creates a problem in a system built around productivity. But there's a tension in healthcare that we don't talk about enough. Efficiency matters. Access matters. Providers can't spend unlimited amounts of time with every patient. There are other people waiting who need care. I understand all of that. But efficiency cannot become the clinical goal. The patient has to remain the clinical goal. Then there's another danger where providers become so pressured for time that we start treating the electronic medical record instead of treating the person. Depression, click. Anxiety, click. Suicidal ideation, no. Homicidal ideation, no. Medication, question, continue. Follow-up, 4 weeks, done. Except maybe the patient isn't done. Maybe there's another question. Maybe there's another symptom. Maybe there's something they haven't told you because they're embarrassed. Maybe they don't even know what they're experiencing is clinically important. And sometimes you don't discover that in the first 5 minutes. You discover it because you ask one more question. That experience changed me. Being criticized for taking too much time didn't teach me to become faster. It taught me something very different. It taught me what kind of clinician I do and do not want to become. I don't want to practice psychiatry by checking boxes. I don't want to prescribe medication without understanding what happened after I prescribed it. I don't want to assume another provider reviewed the records. I don't want to assume everyone checked the labs. I don't want to assume that because a patient said no to one question, there isn't another question I need to ask. And I don't want a patient leaving an appointment confused about what I think is happening, what we're treating, what I'm prescribing, or what they're supposed to do next. Does that mean I'm going to catch everything? Absolutely not. Psychiatric providers are human. Medicine contains uncertainty. Patients can deteriorate despite excellent treatment, and sometimes terrible things happen that nobody could reasonably have predicted. That's important for me to acknowledge, especially when we're discussing a case involving the deaths of 3 children. But uncertainty doesn't give us permission to stop being curious. If anything, it requires us to become more curious. And that's why this trial has made me think so much about my own practice, not because I'm sitting here saying I would have prevented this. I cannot say that. I wouldn't say that. But what I can say is cases like this should make every psychiatric provider willing to ask, do I have the whole story? Have I reviewed the records? Have I considered medical contributors? Do I know what medications the patient's actually taking? Do I understand what's happening with their sleep? Has their functioning changed? Does their diagnosis still fit? Is this patient appropriate for a brief follow-up today, or do I need to slow down? Is there something here I haven't asked about yet? Because that experience at my previous job ultimately reinforced something I believe very strongly today. I don't want to practice psychiatry faster. I want to practice it better, thoughtfully, carefully, ethically, and with enough humility to recognize when the story in front of me is telling me I need to look deeper. What I hope we can learn from this, and before I close, I want to say this is exactly why I opened my own practice. I was not willing to do psychiatric intakes in 30 minutes or 45 minutes. When I first started, I did intakes in 90 minutes. Now I've gotten better and I do intakes in 50 minutes and 2 50-minute appointments. If they are seeing another psychiatrist that's providing medication management, I educate them about you really need one prescriber, because when you have 2 prescribers providing medication, it gets very complicated. Yes, we could talk to one another, but still, my question is more along the lines of exploring. Let's talk about the reason you're wanting another prescriber. Let's talk about why you're afraid to go back to your original prescriber and tell her the things that you're telling me to get the medications that you're asking from me. Now, if you come to me seeking a second opinion, that's a different thing. I'm happy to give you a second opinion and be like, yeah, this medication seems like the right medications based upon what you're telling me today. And then they go back to that original prescriber. But I would not say to a patient, hey, if they're going to be going off a medication, what's called tapering, and I say, I'm going to be on vacation next week, let's start your taper, or follow up with another psychiatrist with a taper, that I would not do. If I'm making changes, the patient needs to do that with me. They need to taper or reduce that medication with me. And then let's talk about follow-ups. Follow-up, depending on how the patient has done. You already heard about the 25-minute appointments 3 times. Patients aren't doing well. They're not stable. We're starting new medications. We're taking them off medications. They're seeing me over a week to 2 weeks. That's just how it is. And then as far as telehealth, if you're under 18 and you come to see me, you have to be in person. If you're over 18 and you live in North Carolina and you want to see me via telehealth, there's a screening that happens before we start treating you that decides, are you an appropriate patient to be seen via telehealth? And if we start treating you via telehealth and something comes out that it tells me that you're not an appropriate patient for telehealth, then one, you can drive to my office for treatment, or two, we help find you another provider in your area that you can go in person and see. The third thing is, if you live in my area, you have to start coming to my office. I won't see highly acute patients via telehealth. So telehealth is wonderful, don't get me wrong. In today's society, people work, we're busy, we are parents, we have jobs, we have certain times that we can do it. But telehealth is easy. Log onto the computer, log off. But when you're really depressed or really anxious, or maybe you are psychotic, logging onto that computer and logging off does this. And I have learned this in my many years of practice. You close the computer, you go back to bed and cover up your head. Or you close up the computer and that psychosis, those voices, they return in your head. If you sit in my office and I'm watching you for 45 minutes, I usually can tell if something else is going on in your head. There'll be some silence. You can see the patient better. You can see how they're moving. You can see if their leg is bouncing up and down. You can see their hand motions. You can watch their eye contact a little better. They're not distracted by things at home. So yes, telehealth has a place, but in-person appointments have a place. So labs. I order labs on every new patient if they have not had them in a year, and then I coordinate care with primary care provider, because there are labs that can make a difference in how I treat you. Thyroid, vitamin D, those kind of things. They can make depression worse. And then if you don't have a primary care provider, I help you find one. Also, if you don't have a therapist, and I'm not accepting new therapy clients because I do therapy and medication management, those appointments are 50 minutes. If you don't have a therapist and I'm not taking new therapy patients, I do the medication management and help you find a therapist. So there are many different ways to do this, but I do not see patients who see other psychiatric prescribers, whether it's a psychiatrist, a psychiatric mental health nurse practitioner, or primary care if they're prescribing psychotropic medications, which means medications that like SSRIs or SNRIs or medications that are for psychosis. I coordinate care with the primary care and say, hey, they reach out to me, they want me to prescribe these medications, is that okay with you? And most of the time primary care is fine with that, because they're like, you are the expert, you prescribe those medications, I'd rather you do that. And then we coordinate care together. If I make changes, if they're getting worse, I reach out to primary care. But I do not see patients if they're seeing multiple prescribers, and that is outlined at the very first appointment. Do you want to see me, or do you want to see somebody else? And I tell every patient, you're not the right fit. Sometimes we're not the right fit. You may not like me. I may not want to prescribe what it is you're wanting. And so therefore, I'll give you a list of referrals that I know of that you could go see, and maybe you could find a better fit. Also, something else I do get all records. They're electronic. We don't have to worry about pieces of paper like at my prior practice, where quit requesting every medical record. They're all electronic. If they're not here in 30 days, I follow up. And then the other thing is, so running my own practice allows me to set the amount of time I'm seeing the patient, the labs I order, or the labs I order or I request from primary care because I've had them done within a year. How much time of the medical records I request, and how often you see me, and whether it's telehealth or in person. So in bigger hospitals, they often only allow prescribers to see patients for 25 minutes, because I think I've said this before. If you're charging $200 or $300 for a 25-minute appointment, let's say $300, that's $600 an hour if you do two 25-minute appointments. If you're seeing them for 50 minutes, that's only even going to be $300 an hour. So the big hospitals are losing a lot of money throughout the day, whereas a smaller practice for me, I don't care. My patient is my priority, not the amount of money I'm bringing in an hour. The safety and the health of my patient's always the priority. So as I close this video, I want to come back to why I decided to talk about this case in the first place. 3 children died: Cora, Dawson, and Callan. Nothing we discuss about psychiatric care should ever allow us to lose sight of that. And I also want to repeat something I said at the beginning. I did not evaluate Lindsay Clancy. I was not part of her treatment team. I have not reviewed her complete medical record. And I'm not sitting here telling you whether she was legally responsible, whether a particular provider was negligent, or whether this tragedy could have been prevented. Those are very different questions. But I do believe psychiatry can learn from these different cases. And maybe one of the biggest lessons is that receiving psychiatric care doesn't necessarily mean someone's getting better. When a patient continues to get worse or have more symptoms, we have to notice when the symptoms no longer fit neatly into the diagnosis we've been treating. We have to notice when medications keep changing but the patient is improving. We have to notice when sleep is disappearing, when functioning is changing, when the family is saying something is different, when the patient is saying, I don't feel like myself. Those things matter. And sometimes the answer isn't immediately another medication. Sometimes it's, I need more information. I need to ask another question. Maybe I need hospital records. Maybe I need to speak with another provider. Maybe I need to collaborate care. Maybe I need lab testing. Maybe I need to reconsider the diagnosis. Maybe this patient needs to be seen in person. Maybe they need a higher level of care, or maybe I simply need a longer period of time with the patient. And that brings me to something that I deeply believe in. I don't want to practice psychiatry faster. I want to practice it better, thoughtfully, carefully, ethically, not perfectly, because there is no perfect psychiatric provider. We cannot predict every outcome. We cannot predict every tragedy, and we should be very cautious about looking backward after something horrific happens and convincing ourselves that the outcome must have been obvious beforehand. It often wasn't. But that doesn't mean we stop asking, what can we learn? Because sometimes the difference between understanding and misunderstanding a patient is another question, another record, another lab result, another conversation, another call to a family member or a provider, another 15 minutes. And in a healthcare system increasingly focused on efficiency, productivity, and getting to the next patient, I hope we never become so efficient that we stop becoming curious about the person sitting in front of us. Because psychiatric care isn't about prescribing medication. It isn't just about assigning a diagnosis, and it certainly isn't about checking enough boxes to complete a note. It's about understanding a human being, and humans don't always fit neatly into 15 minutes. If you're a psychiatric provider watching this, I'd love to know what this case has made you think about in your own practice. And if you're a patient or family member, I want you to know something too. If something is changing, if you're getting worse instead of better, if medication doesn't feel right, if you're barely sleeping, if you are experiencing thoughts or symptoms you're frightened or embarrassed to talk about, tell your provider. And keep asking questions until you understand the treatment plan. Ask, what is the treatment plan? Because sometimes the most important information in a psychiatric appointment is the thing that almost didn't get said. I'll continue to follow the Lindsay Clancy trial, and as additional psychiatric testimony develops, we'll talk about what it does and does not tell us. And if you have not subscribed to my channel, please do so. I don't know if you've heard, but YouTube is going to be changing in February, so I'd really like to hit 1,000 subscribers before February. And so a few things, if you subscribe, it's 100% free, so hit the like, subscribe button. I'd so much appreciate that. Again, it's 100% free. And also, we'll be doing some lives eventually where you can come on, ask some questions. I want to get a few more subscribers before we do that. And if you have a topic you'd like me to cover, please reach out and let me know. I have a new video that was of your request that's going to be posted coming up very soon. And so please subscribe. It's free. Help me hit 1,000 subscribers before February 1st, 2027. And I really do appreciate you watching more than I can say. This has been a very long video. Thank you for sticking it out. And let me know what you think about what I said today. And please be nice to everybody in the comments section because this topic is very sensitive. And until next time, be kind to your mind.